Hello, can I share an episode that occurred with me while we were waiting?
Yeah, sure, absolutely.
I was doing an ultrasound in a newborn baby and a preemie, and the mother looked to the screen and said, "Oh, my baby has a bamboo in his lungs." It was really funny.
It was amazing. And
Yes.
yeah, I think it just gives us recognition of the
mother recognized the pattern.
Pattern recognition is such a powerful tool. And I mean, even in echocardiography, I have a colleague who's kind of trained me in Bristol, Beverly Cy Goodman. She's one of the pediatric cardiologists who works in St. George's. And I mean, she focuses a lot on pattern recognition in cardiology as well. So it is a very, very powerful tool.
The normal, and something is not normal, even we don't know what, but it's important to recognize that.
Absolutely.
Yes, but it was funny, the mother saying that.
So we're 7 exactly. I'm just going to do a little bit of housekeeping while we're waiting for a few people. So we have 2 more sessions of workshops, including today. Today, we're going to do a little bit of respiratory distress syndrome after peer review. But most importantly, from my perspective, the next session that I do on the 1st, in particular, will cover mnemonic kind of appearances, as well as consolidation atelectasis, kind of how you differentiate the 2 of them. So with this session, our kind of workshops for a period will end. And what we will then be delving into is the 3rd part of our module, which technically is very, I would say, expert driven, and that we'll be looking at approaches. And in particular, the talks that will be provided by Almudena and the lovely Adele, we won't be having peer review sessions with them in order to facilitate discussion for everybody. So there'll be sessions which are kind of one-to-one, where they present to us, and then I would like to hope that you guys have lots of questions from those sessions, because clearly that's where lung ultrasound is actually headed. But after that, the remaining sessions peer review will resume. It's also to say that between the 1st and the 9th of March, until such time as we have completed those sessions, we will be having new content coming up, which will be remaining chapters. So again, take your time. We're not in a hurry. So the intention from our perspective is that we finish presentations, but theoretically the peer review will carry on. And I mean, we'll be doing peer review for 3 months, but even after that, for a bit, we'll be carrying on with peer review. So please do not feel too anxious if you haven't started kind of your logbooks yet. I think what I would say is it's never too late to start and put a probe on the baby. But what I am going to do is I'm going to let Anna start. Go for it, Anna. So I'm just going to press record very quickly. For it, Anna.
So I'll present a case. It's not a newborn, it's a 3 months boy, but I thought this was interesting to see the images. He was in the pediatric with an RSV positive. He was in non-invasive ventilation on CPAP with oxygen. And on day 8, they called me to do echo, a TN echo, because he was worse and with tachycardic, and they heard a murmur in the heart. So I went to do the cardiac ultrasound and couldn't resist to do also a lung ultrasound. because he was worse from the respiratory distress with fever and a high CRP that in our units is above 10, and he had 70. Okay, so let's see the scans. Okay, this is the right lung, and I think we have 3 intercostal spaces. We have the bed sign, and the pleural line seems regular. A few comet tails, and the A lines predominant in all the right lung. So I didn't saw anything that could explain the worsening of the breathing of the baby in these scans.
Beautiful. Yep, I would agree. I would agree with that. Yep.
And in the left lung, the same. The lung was sliding with a profile and some comet tails and 1 or 2 B lines, like here. It will appear here, 1 B line, but nothing that worries. It's in a normal lung. And then I turned the baby, so I did the posterior scans after that. I didn't wait. But I think we can see in the posterior scans that there were not normal lung.
Yeah.
In that time, it was before the course started. It was in the end of December. I didn't realize, but I think this is a pleural effusion.
Absolutely.
Yes.
You've got an effusion
But
there, quad sign.
that time, yes, in that time, I just thought it was an hypoechoic area of consolidation with some bronchograms here and thread sign.
Yep.
But I was a bit confused here. I think these are air bronchograms.
I would agree. Yep, there are bronchograms. Your pleura naturally is a little bit difficult to see the kind of subpleural consolidations because you've got a pleural effusion with lung atelectasis, but you've definitely got static air bronchograms there. A B line in the middle on that right-sided slide, coming down, and what looks like a kind of a compact B line pattern. So, yep, very nice. Yep.
Yes, and I have I was so excited I didn't label it as right and left, but it was on both sides. And here we can see more. And I think here we can see the bronchogram. Really nice bronchogram.
I think that's a dynamic actually.
Yes,
it's a dynamic air bronchogram.
I thought that I didn't do Doppler because on that time I didn't remember to do it. It was before our sessions. I'm sad I didn't that, but now it's too late.
No, don't worry. I think there's a lot of information that we're getting at this particular point, and yep. I'm just. What's the weight on your baby?
500 kilograms.
5.8. So,
yes.
I mean, I think your early images, my only comment would be the depth probably needs to be up. I mean, I'm sure this is one of your early scans, but yeah, you can clearly see again, especially in that right-sided image, what is a dynamic air bronchogram in the middle with, will almost certainly be consolidation. So, yep, very nice.
Just one question, mate.
Yep.
For the previous slide, I think the first one on posterior view, why did you say this is static bronchogram and non-subpleural consolidation? On that one, yes. This one of the right side.
The one on the right side. Okay. So when I look at it at this particular point, I see very bright pinpoint areas. Now, that area in the middle there, where you see a B line coming down, you see those bright areas and you don't see them moving in and out. Maybe on the right-hand side above, I think there is a dynamic air bronchogram there now retrospectively, now that I've seen the other image. But so that, can you see how it moves in and out? So basically what it represents is an area of lung that's solid with air which appears bright on the ultrasound moving in and out. Now, when it moves in and out, that is dynamic. But if it stays in the same place because the air is trapped within the lung, then we call it a static bronchogram. And you can have both. But what I'd say is that when you think of a mnemonic consolidation, in particular, air moving in and out would, or fluid moving in and out, in particular exudate, would kind of give us a mnemonic kind of a clinical picture. And then if you put Doppler on that region, what you're really looking for is whether there's increased vascularity. Because if there isn't, where you have static air bronchogram, then the question is whether you're really thinking of atelectasis or collapse, because you have no air and no blood within it. But yeah, static air bronchograms don't move in and out. They remain in one place. But dynamic air bronchograms will move in and out. So if we go to the next, yeah.
Thank you.
So if you look at this image on the right side, so Anna, if you just, move around, can you see, it looks like a spider's web moving in and out?
Yes, this is obvious.
Yeah.
But what I was confused between the static bronchogram and subpleural consolidation. So,
yep, that's a fair point. And like I said, I'm going to show you lots of images today. Don't worry. We will clarify subpleural consolidation, snowflake sign, everything. I will be talking a lot about RDS today, in particular subpleural and deep consolidations. So I hope by the end of the session, we'll have clarified that.
Thank you.
I think I have only one more here.
Yep.
To see better.
Yeah, you've got a shred sign.
What we call shred sign?
Yes, completely.
It's irregularity.
Yeah.
Okay.
Yep. And again, what I'd say is that, are you using a GE machine, Anna?
Yes, it's a GE.
Okay.
Yes.
So in your GE machine, so tomorrow I'll be putting up a video. So when you go to your GE machine and you want to image optimize, really what I would do is, in such a big baby, I would probably start at a frequency of 10. Do you use a lung preset mode?
Yes.
Okay.
Yes.
So when you go to your preset, what does it default to? What frequency does it default to?
12.
It does. It's exactly like my GE. So what I would do in that situation is, the first thing that I'd always do is, before I default the frequency, I increase my depth to the depth that I really want. And once I've got my depth, I will drop the frequency to a point where I can see the entire depth uniformly.
Yes.
And you stop the frequency there. And then on the GE, there are two image enhancement features. One of them is sharp mode on the right side that you can use. And you can see that your image is a little bit blurred. So the sharp mode will give it a little bit of fine texture. And then the other thing that you can do is you can enhance your image a little bit by actually increasing the reflectivity. So what that does is that normally sound waves are bouncing off, and you can see you've got the slightly blurred appearance. But actually, by increasing reflectivity, it enhances the effect of the sound waves coming back, which makes your image sharper. But for the people who are using a GE, I'll be posting a video tomorrow to show you exactly how to do it. And a really good thing is, I have a real problem with using lung presets, because you have to individualize to your baby to optimize your image. So use your preset. But in the GE, the beauty is you can actually press the frequency button and you can actually move it up and down.
Yes.
But what it will do is take you out of the preset, and then you can alter reflectivity to increase, the reflection of the sound waves back to give you a slightly sharper, better image. But this is, clearly very consolidated lung. Do you have the chest X-ray by any chance?
Yes, I think I have it here. This was on the day I did the lung ultrasound, and this was 2 days later. So the ultrasound showed earlier.
Yep.
The problem.
And the posterior areas of the lung. I mean, interestingly, again, I just want to kind of emphasize to the group, my friends, we picked up an effusion, we picked up lots of consolidation. On that lung field, we picked up static and dynamic air bronchograms, lung fields that show consolidation in the posterior fields. Now, if you look at this chest X-ray for this baby, I don't think it gives you that information, certainly nothing about the pleural effusions. So, I think this is the beauty of the information that you get from lung ultrasound. Well done. Well done. It's a very nice case. Was the baby RSV positive? He was RSV positive.
Yes.
Yeah.
Yes.
Yeah. Yeah.
Yes.
Thank you so much.
Okay, thank you.
So, as Mayank has highlighted, never neglect posterior zones. So, especially if you're thinking about consolidations and pneumonia and the baby is supine, I think you really risk missing things. So, Mayank, are you happy to go next?
Yeah, I'm sure. I'll just share my screen. Are my slides visible?
They are visible. You can go to slideshow mode. Thank you. God bless you.
So this case was an antenatally diagnosed hydrops due to cardiac arrhythmia. The fetus had supraventricular tachycardia, but the fetal heart rate was controlled on digoxin. The baby was born at 36 weeks with a birth weight of 2.6 kg through elective LSCS in view of non-immune hydrops. The baby required extensive resuscitation, had to be ventilated with high pressures, also underwent bilateral pleural tap for poor chest rise, and we could aspirate around 35 ml of the strokeal fluid. The baby was intubated since birth, and the baby was on very high ventilator settings. The settings were assist control mode of ventilation with a pressure set at 22 upon 6 centimeters of water and 90% FiO2. The spontaneous rate, the baby was a little bit tachypnic, going up to 70 per minute, and there was visible skin edema, and there was a poor chest rise. So I did this lung ultrasound at 2 hours of life with a linear probe at 9.5 megahertz, and I set the depth as at 5 centimeters. I was mainly looking at lung profile, residual pleural effusion, and any need for suspectant. So I have obtained the right lateral and left lateral images almost at a posterior axillary line, and I'll tell you why. So this is on the right side of the lung. So this was quite surprising for me. All of the reasons had A prime profile. So I cannot see any sliding whatsoever. This is a complete A profile. So I would say is A prime profile in R1, R2, R3, and R4. So
Mayank, Mayank, sorry to interrupt. I apologize. This is post-tap or pre-tap?
This is post-tap. So the baby is now inside NICU at 2 hours of age.
Yeah.
And I was actually, the baby was on very high settings. So I wanted to look if there's any RDS like picture or any residual pleural effusion, but I found this.
G.
Okay, so so this was A profile, A prime profile in all the reasons, and I took basically there was no difference in any area when I took the images even at lateral the normal R3 and R4. So I moved even a little bit more towards the posterior axillary line, and these reasons were obtained almost at posterior axillary line. So now when I went to the left side, again in L1 and L2 there's A prime profile, and in L3 and L4 again these were obtained at the posterior axillary line. So finally I could see lung sliding and a lung point in L3, and in L4 I could appreciate pleura which was irregular and but sliding well, and the areas which were seen were B profile, and but there were also A lines present intermittently. So I could find a lung point on L3 and B profile on L4. I complemented these regions with a transverse scan in L3 region, and I could appreciate a lung profile
very
more
nice.
beautifully. So I can see again a lung point. So this is L3 lateral region. I am transverse. So so I could appreciate a good lung point, and they were from other regions. I could see just a barcode sign everywhere in R1, R2, R3, complete right regions, and in L1 and L2. So, so, so my interpretation based on these findings were bilateral large pneumothoraces, while and I was thinking it would be more on the right side than the left, because I could not find a lung point on the right side. So this is the lung X-ray, chest X-ray, and this bilateral pneumothoraces. And but it is quite difficult to comment which side is larger. So my final diagnosis was, and this X-ray was obtained just 15 minutes after the lung ultrasound was done. So we had picked up pneumothorax actually prior to the X-ray, and we even in fact did the trans elimination test, but it was not positive. I'm not sure why, but it was not positive even on maybe it was because of the ambient light probably, but this was the trans elimination was negative. But we made this diagnosis on the ultrasound and confirmed it on X-ray, and went ahead for intercostal drainage. So after intercostal drainage, we could appreciate. I have taken only for reference for on the right side, and now I can appreciate this. The sliding is still less, but now I'm reassured that there are comet tails, and I'm sure that I'm looking at the lungs, which are quite aerated well, even on the R2 and R1, both the reasons. And this was the X-ray which was obtained after post intercostal drainage, and we can see this resolution of bilateral pneumothoraces. However, I can see a small rim of air, which is suggesting pneumomediastinum, but as such, the pneumothorax has resolved. So this was the case.
Yeah, it's beautiful. I have no critique to give. Let's go back to your images. Beautiful images. So let's go back to your first slide. So again, what I'd say, I'm just curious. I mean, clinically, correlation quite important. So the baby came. Did you tap in delivery suite, or did you tap on the unit?
We first aspirated, tapped in the delivery room itself.
Did you use cannulas or a butterfly, sir?
We used cannula.
Okay, so amazing. So you've tapped, and I mean, antenatal diagnosis. Was this antenatal diagnosis? Of,
Yes, this was
yeah,
antenatally diagnosed hydrops.
sure,
So
sure.
the case was referred at 34 weeks, and at that time there was the heart rate was totally uncontrolled, around 300 beats per minute, and the mother was started on digoxin, and after a week or so, the heart rate got controlled, the fetal heart rate got controlled, and then there was some resolution in hydrops, but the baby delivered at 36 weeks.
That's amazing. So, I mean, classically, you can't see any pleural sliding in any of these slides. And I think, again, what I'd like to highlight to all of you is whatever movement you are seeing is basically ventilator air moving in and out. And you must, from your perspective, not get confused between that and pleural sliding. But by chance, if you are confused, and in particular, the image that does lead to a little bit of confusion is, in my mind, at the moment, it's the R2 image, where I can understand if somebody thought there might be. There are no those aren't comet tails and those aren't B lines. The density that you see, this is absolutely not the case. So very nice. And I mean R3, the bamboo sign. I don't think you'll get a better image of the bamboo sign. So beautiful images. So we'll go to the next slide. So again, a replication of the fact that you've got L2, L3 with no pleural sliding and what looks like an A prime profile. And then you can clearly see the lung point coming in very beautifully at this particular point. The depth, what depth are you at, sir?
5 centimeters.
Yeah, so that's good depth. You can see the tissue all the way down to the bottom. And in situations like this, when you see the double lung point, I mean, I would say that once you start going and finding a lung point in the L4 area, you have a pneumothorax going all the way from the front to the lateral region. That's quite significant. So well done. Very good images. Barcode sign again on your next slide. It's beautiful. This is a very nice image of the transverse lung point. Now, just remember that you're technically looking at one intercostal space in L3. So it's worth, when you're labeling it, just labeling which intercostal space you think it is.
Okay, right.
Yeah. And it's to say to everybody that actually this is a longitudinal scan. If you did the intercostal spaces above and below, you'd actually be able to see lung sliding all the way in the anterior part of the chest and the lateral part of the chest until you identify the lung point. So it's, again, a very beautiful image with a barcode sign. My compliments, sir. Any questions from my colleagues in the audience? Does anybody want to ask Mayank any questions? I've got Rana. Yeah.
Yes, thank you. I've got a question. Can you please show us the bamboo sign again?
Okay, I'll go back.
Thank you.
On R3.
So you can see parallel A lines equidistant from each other. And classically, what you're seeing is these A lines are not getting attenuated. So they're actually enhanced because the pleural A lines, the pleural reflection is basically being enhanced by reverberation artifact. So that is classically what we describe as the bamboo sign, Rana. Dr. Rana.
Thank you. Just call me Rana. Thank you.
Okay. Any other questions?
Yes, Alok. And the M mode, do we see the lung point?
Not in these images, no, but I'm sure maybe maybe the next time Mayank says,
take care.
it'll be nice to, it'll be a beautiful image to see the lung point. Because it'll be
Definitely. I'll try to include. I had one question on the L3 image itself.
Yes,
so what I'm looking at is definitely a lung point, but I was thinking that this was I couldn't find
A lines.
So I was a little bit confused.
I'm glad you asked that question. So my only comment over there is that you're not entirely parallel to the line.
Perpendicular.
So today, perpendicular. My apologies. So I mean, today I've been doing a scan with two of my colleagues. That is the lovely Dr. Galia and the lovely colleague of mine, Dr. Latif. And classically, the point that we were trying to make was you really need to be parallel. The problem is because you're not parallel, your sound waves are not bouncing off the pleura to give you the reverberation artifact. So you're a little bit oblique rather than being actually. So when I mean perpendicular would be transverse scan, but you need to have good contact. And the problem when you go into the axilla is you tend to lose contact in the upper end. So again, what I'd say is if the baby is physiologically stable enough, get somebody to abduct the hand so that you can get good contact. So, but yeah, I mean, clearly visible lung point. So my compliments. So we'll go to the next colleague who I have got at the moment. My apologies. I have got Doris.
Hi, Alok. Hi, everyone.
Hi, Dr. Doris. How are you?
I'm fine. Just share my slide there.
Very nice cases today, everybody. Very nice cases. Oh, yes.
Sorry, no, my slides are not. Let me just go and open.
No problems. Any questions, anybody? Well, Well done. That's visible.
Okay. This was an interesting case over the weekend I saw. So this was a 27 plus 6 weeker, 840 grams at birth, born by emergency section for abnormal CTG, abnormal Dopplers, and absent EDF, and was quite growth restricted. He was born in relatively good condition, had managed to get delayed cord clamping, and came out, cried, and was transferred to the neonatal unit with face mask, CPAP, in about 30% oxygen. Because he was small and he was had increased work of breathing, we decided to give him Lisa whilst he was on BiPAP. But about 30 minutes to 1 hour afterwards, when I noticed that his work of breathing was getting worse, and the gas dawn showed respiratory acidosis. So we just selectively intubated him. And then because we were already giving him Lisa, but his oxygen requirement had gone up, and so we just gave a second dose of Curacef. So after he was given a second dose of Curacef, he developed a right-sided pneumothorax. Unfortunately, I wasn't around for that. I came back the following night only to hear that. So a chest drain was inserted. So when I came back, he was about 28 hours of life. So I did a long ultrasound scan. So he had a chest drain. The drain had stopped bubbling. So we were on the verge. It was very stable, was in less than 30%. So it was like, okay, maybe it's time to clamp the drain and take it out. I'll talk about the rest of it. So sorry, I should have put the x-rays at the end. So I forgot and put the x-rays in front.
No problems.
But I'll just talk through. So the first x-ray, so he had Lisa while he was on BiPAP. And then when he was reintubated, this was the x-ray when he was reintubated. So it appeared that all the first Curacef went all the way to one lung, because the left lung, as you can see, lots of air bronchograms, and did not appear well aerated. They pulled back the UVC after this. So they gave a second dose of Curacef. And within a few hours shortly afterwards, he said desaturating, FiO2 went up, then they transilluminated, and they were quite convinced that there was a pneumothorax, and they did a chest x-ray. As you can see, he had a large right-sided pneumothorax. It wasn't under tension. He was said to be quite stable, and his FiO2 hadn't gone up remarkably. So they put a chest drain, and after this was the x-ray after the chest drain. So which showed that it really helped, and he just had a small rim of them still present. So it was, I did the ultrasound when he was about 28 hours of life, which was most likely more than 12 hours after he had the chest drain inserted. So starting with the right side, so it was actually, it was quite a difficult scan because he had a dressing over most part of the right side. So I was trying my best not to in any way upset him, and with the chest drain sticking out. So I had to keep moving my probe around the bell. I was using a hockey stick. I increased the frequency to 9, and the gain was about 4. And so looking at this x-ray, as you can see, the aspect there, quite a bit of dropout because of the dressing and the line, but I had to just keep moving my probe around. The drain wasn't bubbling anymore. So it was difficult to see the outline of the pleural line, but I can identify 3 ribs. But the pleural line, from what I could see in this view, I couldn't really appreciate it, but I got all this, I thought there were more subpleural consolidations. I could appreciate that the pleural, was sliding on this aspect, and I could see mainly B lines. I couldn't really appreciate a lot and much of A lines. So I moved my probe for that. I just moved it from left to right, longitudinally. And when I moved it a bit, I could see the pleural better, but I could still appreciate this area of subpleural consolidation.
Yep.
The pleural was sliding up to here with lots of B lines, but I couldn't really see much of sliding after that, and I thought this was more of A-line. So I kept trying to move and manipulate my probe a bit to see why that area was dark and why I couldn't appreciate much of pleural sliding. I was so sure that the pneumothorax had resolved because it wasn't bubbling and there was no air coming out anymore. It wasn't blood. I couldn't see any bubbles in the drain, and he was in less than 30% oxygen. But I was a bit curious, why is that side not sliding? Whether it was, I thought it was more of the dressing. So I carried on, and I went to the lower area, the R2 area, the lower part of the right lung zone, and I could appreciate that the pleural on that side was looking so irregular and broken, and looked. I would say this is more of subpleural consolidation. Also, but we can still see the outline of the pleura on the right hand side. I could appreciate that there was some pleural sliding, but this area didn't seem to be moving as well. And I could see A lines. Yes, I could see A lines there. So I tried to go to R3, but this was where the drain was sticking out. Right, I could appreciate the pleural. There was pleural sliding, but up to here, I couldn't really appreciate much of pleural sliding. Now, I couldn't really get an M mode at this point. So then I tried to move the baby a bit to try to get the posterior area, but I could only place my probe on the posterior axillary line and to get this view. So the pleural seemed more regular and less thick on this view. You still see this area where it looked a little bit irregular and broken. There is pleural sliding, but after a while, I lost pleural sliding and contact, mainly because of the dressing and the chest drain. Now, on the left side, where the lung was not well aerated at all, it seemed to appear that all the curoseph went into the right side. You can appreciate also that how it looks. The pleura, you can see it's very irregular and it's certainly not smooth. So all these areas of pleural consolidation, and I could appreciate compact B lines. I couldn't see any A lines, and the pleura was sliding. So because I was thinking about subpleural consolidation, whether this was more of consolidation, I tried to do Dopplers, but let's see if it will play. But this is what I was getting. So I don't know whether this is artifact or this is real. To say that this.
My only comment would be, I don't know what scale you're using, and really what you'd have to do is, because if your scale is very high, you will get speckling, which I think you're getting speckling here as opposed to there really being a vessel. But when we do consolidation, collapse, and pneumonia in the next presentation, I'll kind of go through scales and how you adjust it. Okay. So my gut feeling is you're just getting speckling because you've got quite a high scale at this point. Oh. But yeah, beautiful subpleural consolidations. But I'll let you carry on, please. Yeah.
Okay. So as you can see on the left side, they had very compact B lines, lots of subpleural consolidation. I did not do the L2 view because I kept getting the view, so I just went to do L3. And it's as we can see, the subpleural consolidations are persistent. The pleura is so irregular that it's difficult to see a proper outline of a pleura. You can appreciate lots of B lines. This area, I wasn't certain whether these are consolidations or air bronchograms.
I think they're air bronchograms below. Yeah, and yeah. I'd say they're probably static. You know, they're there. They're not kind of moving in and out. They're just disappearing and appearing with inspiration and expiration. So I would say that's a static air bronchogram. Which machine are you using?
I'm using the GE, and I use the hockey stick.
Sure. So again, with the next session, what I'll do is I will be posting how you can optimize the image, but you're just a little bit blurred at the superficial part of the margin. You can make those images a little bit more crisp by using the sharp mode. Just on L3, so you're looking at the top of the image. Yeah, beautiful. So there is a deep consolidation there. which again, it could be consolidation collapse, atelectasis, or it could just be a consolidation. But again, you can see if you had a little bit more gain, what you'd see is static air bronchograms within it that look bright. So they wouldn't be subpleural consolidations. So that there's just a deep consolidation there. And again, it just highlights the importance of, having adequate depth to pick up. But yeah, beautiful images. Just with the L3, this is that the grades and severities of subpleural consolidation now, which have been classified by Jing Liu. And I mean, that would basically be grade 4. And what he classically describes as a very severe snowflake sign. But I'll talk about that in my talk today. Beautiful image, very nice. Do you have any others to show?
Yes, I did quite a few scans for this baby. Yeah, so these are more of the L3 images. I would skip them because we've already talked about them in detail. Okay, so after 28 hours, he started desaturating, and we picked up that he had pulmonary hemorrhage. So I did another scan at about seven hours afterwards, so about 35 hours on him. Yeah. So starting with R1, so I could appreciate there was such a difference. The pleural was looking worse. As you can see, it's
fractal sign.
Yeah.
Very severe. Yeah.
Yeah. So what sign did you call it?
Basically, this is shred sign, fractal sign.
Yeah.
So yeah,
which is worse than the last image, and this is the right side, and the pleural is sliding, but the B lines are much more compact. You can barely see any A lines, and they are sliding.
Yep.
And R2, just the same. You can, the shred sign is so evident. Compact B lines. But this area didn't seem to be moving as much, and I don't know whether I would say that these are A lines. I couldn't get it wider to say that these are A lines. Now, after the X-ray, after the first ultrasound I did, the drain started bubbling. So I clamped it initially, but he said desaturating. So when I opened it, it started bubbling again. So then I did this at 35 hours afterwards to see, okay, I mean, what was going on. But in retrospect, I think the first scan I did, the area that the pleural wasn't sliding, that the pneumothorax was still present. I couldn't get an end mode because every time I tried saving, it wasn't picking up. But I got with later scans, I will show you the end modes that I got.
No problems. So just in R2 for everybody, I think Sharif was asking me a question, or was it? So you can see dynamic bronchograms. Can you see in R2 at the top? So can you see air moving in and out? So it's like a little bit like a snake moving in and out. So those are dynamic air bronchograms at that top end. So yeah, and I mean, you've got a very severe fractal sign, and I think that on the right side of that image, you still have some air. I'm not sure the pleural is sliding, and my gut feeling is with a little bit of better resolution, those would be parallel A lines. But yeah, an M mode would definitely help in this situation. So very nice images, not so nice for the baby. Yeah.
So R2, I was actually trying to look for the long point at this point to see, to try to pick it up. So because the pneumothorax, I knew it was on the right and it seemed to be in the lower areas. I was trying to get the long point clearly. So here you can see the B lines, the pleural sliding. And beyond that, I could see A lines. And
I think that is the long point.
Yes, his pleural is not sliding at this point.
Very nice. Beautiful.
I managed to get the R3 view. Also, you can appreciate the pleural, but you still can see how irregular it is with pleural, so pleural consolidations, sliding, and mainly B lines. I don't know what this is, whether this is an artifact. It's maybe the dressing or the chest drain, because chest drain was just around that area.
It doesn't seem to be moving at all, so it must be artifact.
Artifact, okay.
Yeah.
All right, so he had developed pulmonary hemorrhage. This is at this point anyway, so this scan was after that. So I did the left side to see if there was any difference. It was difficult trying to keep my probe as perpendicular as possible. So I don't know if that's why this view of L1 is like this. It might be to avoid the heart and also try to keep my probe.
So what's your baby's weight? This baby
840 grams, 840.
My gut feeling is, so the problem that you're facing is because you're using a depth of 5, which I think, from my perspective would probably be quite deep. 4 centimeters in an 840 grammer will allow your image square to be wider.
Oh, I see.
Yeah, so you'll get a slightly wider square, which kind of means that your resolution will be slightly better. So, 4 should be sufficient in a baby like this. But yeah, what you've got is very irregular pleura, and you're losing a little bit of the pleural line as you go superiorly because you're struggling with alignment. But again, what it shows is very, very irregular destroyed pleura with what looks like, to me, basically compact V lines in inspiration, probably AIS when the baby expires, all those compact V lines merge completely. And similarly, again, a snowflake kind of appearance with very severe irregular pleura with what looks like a completely AIS kind of profile. So, yep.
This is mainly the left lung. For some reason, it seems as if all the QRCEP went to the right lung and the left lung remains uninnervated. So, right. So 53 hours afterwards, so the chest drain is still bubbling. The pleural pulmonary hemorrhage had improved, and I thought I would do another scan to see, but the chest drain was still bubbling. So this is R1. So the pleura now seems more regular.
Yep.
We can see, I think mainly comet tails, but you can still appreciate B lines and pleural sliding.
My gut feeling is that's still an AIS profile.
Yeah.
My gut feel, and I think just your subpleural consolidations have kind of coalesced. Your pulmonary hemorrhage is resolved. Your pleura looks a little bit more regular, and so yep, absolutely. Question is whether you might still have a small bubble there. We call it a bubble. So just on that left upper side, yep. So if you just take your, so if you just go to the extreme left there, that dark area.
Okay.
Yeah, the question is whether that's a lung point, and whether the pleura is not sliding and you have a small bubble over there, because you definitely have what looks like a B line next to it. So yeah, it'd be interesting to see what the M mode look like but let's have a look at your M modes. You can see a lung point there.
Yeah, you can see a lung point clearly, and the E lines and the B lines with the sliding. So
my God, you guys have had lots of pneumothoraces over the past week.
I don't know why.
Not you, but I'm just saying, Mayank, yourself, everybody has managed to capture pneumothorasis. So well done.
So I managed to get the long point. I managed to get the M mode because I was really trying to position the cursor and get to see what the M mode looked like. So I think this are the areas where it looks like a seashore.
Seashore, yep, completely. And then you're evolving to a barcode as you gradually go on. Yep.
It didn't seem as like the barcode signs that you were showing us, but
it's because your gain settings are on the lower side. I think if your gain was on the higher side, you'd see a much better barcode sign. And the only comment is, again, because you're 5 centimeters and you're probably using a high frequency with a very small baby, you're not getting the deeper regions. So because you're not getting the deeper regions, the deeper part of the barcode completely disappears. My advice would be, you'd be okay at 4 in this, which would give you a wider footprint to be able to see. And actually just your gain settings need to go up, which would give you a brighter barcode. But I can make out very clearly, very easily. And I'm sure the other scan as well, a lung point with what looks like a barcode sign.
Okay.
Well done.
That's it. I think I had, by this time, upset the baby too much, so I didn't do the left side.
No, good. Well done. Well done. So we've got time for one more, and I apologize because we're 47 minutes in. I'm going to get, so there's a toss-up between Suman and Atnafu. So who wants to kind of be the sacrificial lamb and say they'll present first the next time around?
Can I present, Dr. Alok? Thank you.
Is that Atnafu?
Yeah.
Yeah, Atnafu, go for it, Atnafu. And Suman, I promise you're first next time. Is that okay? I apologize.
No problem.
I'm so sorry. Don't worry. We're meeting day after tomorrow. So, and you can present more than one scan.
Okay, thank you.
How many scans have you got, Suman?
Actually, I got one only just this time.
Okay. Okay, let's go through Atnafu's scan very quickly, and then let's see how we are for time.
Okay, sure.
Can I ask a quick question while we're waiting for Atnafu?
Yes, please, Dr. Zahiruddin.
It's really just to pick the brain of everyone is about the correlation in the context of lung ultrasound, the bubbling of the chest drain. To be honest, for me, the bubbling plays less relevant role as I go along while the chest drain is in, especially if the drain is under a low-grade suction or the baby is ventilated. So I don't personally put a huge weight on the correlation between the presence of the pneumothorax continuing to be present and the continuous bubbling. So I'm just wondering what everyone think about about this.
My take on it is, I think we use underwater chest drains with 3 chambers, which will basically have a suction chamber, a chamber which has got water, which basically reflects tidling, and then basically a drainage chamber. And really what I'd say is that what you must not get confused on is the suction causing bubbling in the water-filled chamber, which versus the other chamber where you'll have proper bubbling with air coming through. And if you have a kind of a vigorous kind of a movement of the latter column, then you have a decent sized pneumothorax. But yeah, I'm happy to be corrected by others. Yep.
I agree with you, Alok. Even for instance, in this case, we did not apply on suction to the drain, so all the bubbling was in the underwater chamber, and
yep.
The only way you can, without long ultrasound and even repeated chest X-rays, the only way you can see if there's still an air column or there's residual air leak is that you will still see that the air moving, and it will either be seen in either the drain fluttering or air coming out into the underwater cell. Yeah. Interestingly, in this case, I didn't see that, and I was quite confident that the pneumothorax had resolved. But that was not the case because I did a long ultrasound, the first long ultrasound, and it was like, it doesn't see, the pleura didn't seem to be moving. And then I clamped to the drain, and immediately I did that, the baby started desaturating. And then I opened the drain again, and I could see the air column begin to move again.
No, but if the pleura is not moving, it means that you probably do have a pneumothorax.
Yeah, that's what it meant.
Okay.
I was just not confident. Maybe I wasn't confident with my findings. Like I was like, I wasn't confident. So I think I should have.
That's okay. What I can do is I can circulate a video that we've made on basically the interpretation of chest drains tidling. So by all means, Dr. Atnafu, crack on.
Okay, good afternoon, good evening, everybody. Thank you, Dr. Alok, for everything. Just I will present one case.
So Dr. Atnafu, can you introduce yourself because you're very special. Yeah.
I'm from Ethiopia, Addis Ababa. I'm working in a tertiary hospital here in Addis Ababa. I'm a pediatric cardiologist by profession, but I'm frequently being invited for doing echocardiography in the neonatal ICU, and because of that, I see babies with lung pathologies and cardiac pathology, and that's why I'm interested to just get training of lung ultrasound so that I can help our neonatologists in managing lung pathologies.
It's very kind. Please carry on.
And really, just I learned a lot even though my field is cardiology. I learned a lot in the past few weeks. Thank you, really, Dr. Alok.
Not at all. God bless you. Carry on, please. Yeah.
Okay. So the case was I was asked to do echocardiography, actually. Baby was 39 weeks. Delivery was at 39 weeks with spontaneous vaginal delivery. And birth weight was 3.25 kg. And baby developed respiratory distress right after delivery. And postnatal age was 72 hours, actually, by the time when I do this lung ultrasound. And baby admitted right after delivery to the neonatal ICU with a diagnosis of perinatal asphyxia because baby was having low Apgar score and neonatal tones were depressed, and also with the diagnosis of meconium aspiration syndrome. And since birth, baby was on mechanical ventilator. And as you can see, this is the X-ray of the baby just taken a few hours after delivery. I think there is opacity over here around right upper lung zone. And this was the X-ray taken 72 hours after delivery by the time when I do the lung ultrasound together with the echocardiography. This X-ray was taken because baby is not improving with respiratory condition, even though the baby was on mechanical ventilator for 72 hours on SIMV mode. I think the endotracheal tube is in the right position, as you can see. And I did lung ultrasound on few positions, and this is the finding that I got. So this is L1. As you can see, there is compact B lines on L1 with sort of lung pulsation around here.
Yep.
And this is taken on L3, same compact B lines with a little bit subpleural consolidation around here.
Yep.
And sliding pleura.
Yep. You've also got some static air bronchogram there. So just L3 right in the center.
Okay.
So you've got just below the subpleural consolidations. Yeah, just there. So just below. You're going down, further down. Just there,
here.
where your arrow is. Yeah, that's so. If you play the image, you can see some static.
Yeah. Here.
Yeah.
Thank you.
So they disappear and appear, but they don't move in and out. This is the point I want to make. If Dr. Sharif is here, can we just show Dr. Sharif that previous image, because it's a beautiful image. So
yes, that's very clear. Thank you.
Yeah. So what you can see is that it appears and disappears, and that's because of the breathing, inspiration, expiration, as opposed to kind of moving in and out like a snake. So yeah, go for it. Yeah.
Okay. So this is the previous one was the lung on the left side.
Yeah.
And this is the lung on the right side, R1. As you can see, just pleural sliding, no thickening, few B lines with comet tails actually on R1. And there is also A line.
Yep.
And on R3 as well, pleural sliding, no significant thickening, but there are few B lines and A lines with AB profile. Okay. So what I can say is the left lung is sick, but the right lung is a little bit okay. So
just going back to that image, my only comment is that when you look at R1, are you using a hockey stick?
No, it's a linear probe.
A linear probe. Okay.
Yeah.
So I mean, you've got reasonable depth, about 3.5 centimeters, but you've technically got only, I'd say, maybe 1.5 intercostal space. So you're actually missing the apex. And yeah, so just with the right upper lobe consolidation that you have on the X-ray, you just risk missing that consolidation. So you probably want to go a little bit higher for R1. And if your linear probe has a footprint which is short, you might have to do multiple images with R1. But today, when we have a look at cases, I'll be able to share with you how we do that. So, but yeah, I would agree. Your right-sided lung looks very well aerated. And yep, carry on. Yep.
So just my conclusion is this one: compact B lines on left lung with irregular pleura, possible consolidation on this baby. So what caused the consolidation is a question that I have.
My gut feeling is your tube is down low.
Mhm.
And because your tube is down low, it's causing the right upper lobe collapse. But often when your tube is low, it also basically blocks off aeration of the left lung, which causes a left-sided collapse consolidation. You've got a lot of rib crowding over there. So, yep. The images that you sent me for this baby also had some really nice tissue sign, which
Which
don't.
one?
Yeah.
Oh.
So,
I think
don't worry. You don't
not
have
this
the
one. Not this one. The other one. I have another case.
Okay, that's fine. Carry on then. Yep. But yeah, I would probably agree with you that, you know, at this particular point, you've correctly identified the left lung being you know, collapsed with less pleural sliding, and the right lung showing and being well aerated. So yep, we
should I go to the other case with the
you can
tissue?
you can go to the other case. Yep, that's a nice case as well. Yes, please. So you just go to slideshow mode. Yeah, my apologies. This is case. Yeah, sorry about that.
It's okay. So this is another case actually. Yeah, I'm right. This is another case. 29 weeks. A baby, preterm baby delivered at 29 weeks. Delivery was happened because of maternal preeclampsia, severe preeclampsia. Birth weight was 885 grams, and postnatal age by the time when I did the ultrasound scan was 36 days. He was in the kangaroo mother care, but she developed acute onset of respiratory distress while she was on kangaroo care on 36 postnatal age, 36 days. Then baby put on mechanical ventilator because of severe distress, and she was on ventilator for 2 days. I did the lung ultrasound on 36 day. This was the X-rays by the few hours after, 24 hours after delivery. As you can see, there is opacity over here, and she was managed for highly membrane disease because of this X-ray. She improved and transferred to the kangaroo mother care unit. And this is another X-ray taken at 36 days of postnatal age. As you can see, the left lung is completely opaque.
Yep.
And the right lung actually opacity over the middle zone.
Yep.
And I did the lung ultrasound on 36 postnatal age.
Yep.
This is L1.
Yep.
So I can't see pleural line.
Absolutely.
I can't see the lung at all. And what I see is the ribs, and below the ribs is just the liver size, liver-like structure, completely
Beautiful.
hepatized lung.
Completely hepatized lung. I would completely agree. And few areas of trapped, you know, what I think is air bronchogram. So in L1,
this one.
Yep. And absolutely. So it's completely hepatized. It looks like liver. I wouldn't be able to get a better tissue sign myself. Well done, sir.
And this is on L2, just a little bit below that. I try to avoid the heart, but still I see the cardiac or the heart, the lung pulsation. These are vascular structures. And I applied the Doppler color, and this is what I got.
What's your baby's CRP, sir?
He didn't have the CRP by the time when I did the ultrasound.
Yep.
So venous and arterial pulsations.
Yep.
I'm assuming that these are the pulmonary arteries and the pulmonary veins over the hilar region.
Yep.
And this is also over the L3, the same. Over the L4 also is the same, but I didn't just shown here.
So they're beautiful images. I'm going to put it to the group, guys. What do we think? Collapse consolidation or pneumonia on that left side? So I'm very curious to see what everybody thinks, guys. Everybody has to have an opinion today. It's a beautiful image.
With the Doppler, I think it looks like a pneumonia with lots of vascularity. I can see the acoustic shadowing in between the B bands, which are appearing more beautiful when the Doppler is on. And I think just based on the fact that the Doppler is so vascular, I would go for consolidation. But the onset is so acute, according to the history.
Yeah, that's an acute onset.
So my only comment, if we just go back to that image, is.
Oh, I lost.
Don't worry. So basically what you've got is you've got vascularity in the lower part of the image, but as you go distally, the vascularity decreases. So I'm probably, it could be a mix of both of those things. The other possibility is aspiration, and you might have an aspiration pneumonia. That would be my feeling. And with an aspiration pneumonia, what happens is, like, once the baby's intubated, ventilated, a lot of these babies will have an inflammatory kind of response. You get increased blood flow to that area of the lung that is completely atelectatic. So often it causes VP mismatch. I think you're absolutely right, Dr. Zaruddin. Having a CRP would be very important. My feeling, my worry would be whether this baby's developed an aspiration pneumonia, and that is, like you said, a mnemonic consolidation, as opposed to kind of just being purely atelectasis based on the vascularity. But as you go distally, the vascularity becomes less. And the question is whether that area of lung is atelectatic. My only comment again is, when you're putting Dopplers, try to interrogate each zone. You've got a very big window which moves from the kind of hilum or the deep part of the lung to the superficial part of the lung, and there will always be vascularity in those areas medially, because you have large blood vessels proximally. So, but yeah, absolutely no doubt that is, the tissue sign is massive. Dr. Atnaf, yeah.
I lost the view. I don't know what happened to the.
Don't worry, it's okay.
Can you see my slides?
We can, yes.
You see it?
Yeah.
Okay.
Look, do we see hepatization in collapse or atelectasis collapse?
So yes, you can see hepatization in both. Again, what I'd say to you, can we keep it for the next talk? Is that okay?
Yes, sir.
Yeah. Dr. Atnafu, your screen is frozen. Is this a different case?
I don't know. I lost the view. Should I just leave and disconnect again, or what do you think?
My gut feeling is maybe for today we'll stop the cases here, just because.
That's okay.
Yeah.
That's okay. Thank you.
That's really kind of what we can do is, Mayank has presented, as has Anna. And we really need to get Suman and yourself to present. So maybe if you guys go first the next time around. Is that okay? I think we might have lost Dr. Nafu.
Hello, Dr. Alok.
Yeah. So are you happy to stop share?
Yeah, I'm happy, really. I'm happy.
Thank you. Okay. So what we're going to do now is I am going to share my screen. Once you stop sharing.
So I have to leave. I couldn't stop, but I have to leave and join again.
Okay. I am just going to minimize. I've got too many things open on my desktop, which is creating a problem. So guys, we're back to workshop mode. And I am sharing my screen now. Can you see my screen in slideshow mode?
Yes.
Yes. Okay. So what we're going to do is we're going to talk a little bit about the early management of RDS and the strategies that we use in the clinical context of some cases that we're going to see. Now, clearly, what I'd say is that with the advent of the COIN trial, there was quite a bit of, I would say, emerging evidence that actually babies, 25 to 28 weeks, about 50% of those babies were getting away with CPAP, and you're kind of managing with non-invasive ventilation. But clearly, an important aspect of that is being able to recognize which babies we think really need to have surfactant at an appropriate time to maximize the efficacy of what I would say is PEEP failure and RDS management. So I think lung ultrasound, in a way, we've got really good emerging evidence now to show that we can use lung ultrasound as a modality to help diagnose RDS and help us decide on surfactant management. But a key thing from our perspective is exactly how do we do this? What protocols do we use? Exactly when should we be doing a lung ultrasound? If a baby is completely asymptomatic versus a symptomatic baby, are we reliant on lung ultrasound alone? Do we need lung ultrasound with symptoms? Or do we need to consider the clinical background of the baby? And this is really, really important in that when we look at the study that's been done by Rosalind Bratt, she looked at lung ultrasound scores, and a relative lung ultrasound score of 8 in that situation for an ultrasound done in the first few hours of life was pretty indicative of babies who went on to need surfactant later on. So this has kind of been extrapolated to guide management of babies who need to have LISA or Insure if they're on non-invasive ventilation or CPAP. But I think I would like to just give you a little bit of caution in that I think the study and the score is something that gives validity. There's a meta-analysis now that really talks about scores above 6 actually having a high sensitivity and specificity for the treatment of RDS using surfactant. But the slight problem that I have with it is it doesn't actually look at the individual baby. And this is quite crucial because if you have a baby who's 26 weeks, who's not had steroids, who's a baby boy, then really those kind of babies are at higher risk of having worse RDS. And the question that we really need to think of is, would you use a lower lung ultrasound score to treat that baby versus a baby, say, for example, who's a girl, who maybe, say, is the same gestation, who has had steroids, and who might get treated unnecessarily with surfactant, which is quite expensive in very low-cost settings. And I'm not sure that we've really had a study to define that, nor have we had any high-quality studies. We've had one Spanish study, which basically compares lung ultrasound with FiO2, because traditional European guidelines talk about the use of FiO2 as a cutoff for intervention. But what I'm going to do now is, having given you that flavor, is just give you a few cases to have a look at. So we've got a baby who is 26 weeks of gestation. This is a baby girl. She's had antenatal steroids. The mother went into spontaneous onset of preterm labor. There was no PROM. The mother does not have GBS. Delivery actually they attempted to try and delay delivery with the Dosiban, but were unsuccessful. And this baby ended up delivering at 26 plus 1 weeks of gestation. Actually, with all of the treatment, including having had the steroids, she did well. And she was managed on CPAP and delivery suite after delayed cord clamping. At 2 hours of age, she's currently being managed with a PEEP of about 7. Her FiO2 at this particular point is 30%. And these are the lung ultrasound findings. So this is the left lung. So let's have a look at who we might be able to get. So let's get Dr. Figueroa. Are you able to hear us?
Yes, I am. Do you hear me?
Yeah. Would you like to comment on these L1, L2 images?
Yeah, I think we have lung sliding is okay. And in L1, in the left image, we can see some subpleural consolidations. And this is a clearly B profile in both images. And so, yeah, if this is the images in the whole lung, I would say this is a white lung.
Okay,
and so
yep.
we could.
So we've got some more images to show you. So let's show you some more images. Yeah. But we're looking at the L1 region, and the reason I'm showing you 2 images at this particular point, I'm coming back to the fact that really what you do need to do is get the upper lobe of every lung. And I am using a hockey stick at this particular point, which, as you can see, doesn't give me a very big footprint. So actually, I've taken 2 images of L1. Clearly, I have slightly better contact in the image on the right. So I'm just going to use my laser pointer and my pen to kind of highlight that this is perpendicular. I can see good pleural sliding. And actually what I can see is coalescent AIS kind of pattern at this particular point. But in L1, I have difficulty with contact because I'm sliding into the infraclavicular area, but I can see good subpleural consolidations there. And what is classically described as a snowflake sign. So a snowflake sign is basically a grade of RDS basically defined by Jing Liu, which gives you the appearance of this white multiple areas of subpleural consolidation. So just what in terms of the score, how would you score this based on the Brath score?
2.
Okay, fair. I think that's a 2. Yeah. So fair. So we give this a 2. And what we're going to do now is just move to the L2 regions. So these are L2 and L3. Would you like to comment, Dr. Figueroa?
Yeah, and I think we have the same things here because we have pleural sliding.
Yeah.
We have the subpleural consolidations. Yeah, and the how did you call it? Snowflake.
So L3 gives you a classical snowflake sign. So this is called this. Yeah, this is a terminology again that. And I'll share the article with you today that's been coined by Dr. Liu. So for us, defining the severity of RDS is quite important in that we have grades of RDS that we have defined on chest X-ray. And he has actually done work to define grades of RDS based on a study that he's done on preterm babies with RDS. And basically, the grade varies from grade 1, which is a ground glass appearance, to an increasing severity of appearance of snowflakes. And here you can see, obviously, in the L2 that they don't look as severe. But once you come to the L3, they look big. You have subpleural consolidations that are nearly a centimeter below the pleural line. Again, good pleural sliding in all regions. And how would you score L2?
With 2 again.
Okay, and L3?
2.
Okay, fair. I think that's fair. So at the moment, we've kind of already hit scores of, I assume you've got L1, L2, L3, and
6.
Yeah. So let's assume that when you did the lateral region at this particular point, the L3 is the lateral region. So you've hit 6 on the right side, and let's see what you think about the right lung. So these are still images of the right lung. So what do you think about R1 and R2?
I think
if you just want to score them, yeah.
Yeah, 2.
Okay, fair. So that's 8, 10. And this is just a moving image of R1 that you can see. So again, so I'd probably agree. There's a little bit of aeration there that you can see in R3. So what about R3?
Yeah, R3, I can see some halines. So
Yep.
I could score it like a 1, I think.
Okay. So your total score at this particular point is 11. So I'm just giving you an example of a baby who's 2 hours of age, who has just met a threshold of 30%. Now, I would also advise clinical correlation, but I mean, to give you a good idea, with good PEEP recruitment, this baby didn't have a lot of recession and had a decent CO2. So a pH of 7.3 with a CO2 clearance of about 7.6 kilopascals. So, it's kind of one of those babies who at this particular age, somebody could argue you might want to give a little bit more time. You've already hit a decent PEEP. Some of our Canadian colleagues like to use higher PEEPs. I think I get nervous of using PEEPs higher than 7, in these babies at this particular age. But we went on and gave this baby surfactant using Lisa, and I mean, clearly had a good response. Now, my question to you at this particular point is, there are debates. You want to Lisa this baby, or do you want to insure this baby, or do you want to intubate this baby? And I'm keen to have that discussion with all of you based on lung ultrasound findings of this case.
This baby had some antenatal corticoids.
Yep.
Yeah, probably. I would try Lisa.
Okay. Anybody disagree? I mean, please feel free. So I'm really keen to have all views.
Definitely Lisa.
Okay. So we've got Dr. Leila's kind opinion. Anybody else?
I would I don't know how the baby is clinically. How was the work of breathing outlook and
So I'd say baby's basically stable, not crashing and burning. There is, mild to moderate recession. The baby's not grunting significantly.
Okay.
So Mayank is Lisa.
I guess
I will go with Lisa also.
Okay. Why am I asking this question? And why is there an emphasis? Anybody have thoughts on that?
Weight of the baby at gestation age, that's what worries you?
Fair point. I think, yeah, somebody's got an opinion. Yes, please
Oh,
come in.
yes. Hi, it's Jean here.
Jean.
I read an article that with a very high BRAT score, you're likely to need 2 doses of surfactant.
Beautiful. Okay, that's beautiful. So can I just say that high quality evidence that the severity of the BRAT score correlates with severity of RDS is lacking? I'd say that the kind of concept that you can use the BRAT score for redosing, and I really want to talk about that over here, again, is lacking. I'd also say that one of the problems that you have with the BRAT score that other authors have brought up is the fact that you can have quite severe posterior disease. And in situations like that, you're not really quantifying that in the severity of this condition. So, I mean, not for this case, but you might have a situation where you have a baby who's supine, where the actual posterior regions are quite severely affected, but you've got well aerated anterior regions, and you decide that based on the BRAT score, you haven't met criteria. So there's some fallacies here. And what I would emphasize at this particular point is that you need to contextualize the individual baby. Now, the reason we went for Lisa in this particular situation was steroided, a girl, kind of a situation where when I clinically correlate the symptoms and work of breathing were not severe crashing and burning, but actually I would also argue that if you kind of had an unsteroided boy with this score right at the start, and were in a situation or where the baby needed significant resuscitation, had perinatal acidosis, and or kind of had problems with, significant lack of, beta-methasone exposure, no steroids. I think the risk that this baby has got a high score, this is the first score and it's high. So I'm clinically correlating with quite severe appearance of RDS, would make me worry that actually Lisa might not be the right choice, and I might need another dose of surfactant. And I'm just sharing my experience with you. Two goes at Lisa have not gone down well for the babies that I've managed. So I just wonder whether that's a group of babies, and feel free to disagree. I'm just sharing my experience with you, where while you're using lung ultrasound scores and you're clinically correlating, where you might want to intubate, ventilate, give that dose of surfactant, actually follow the clinical course of the baby. And I'm not saying repeat lung ultrasound. And I want to emphasize this. This is really important. When you give surfactant to extremely preterm babies, especially in the first few hours, actually the lung ultrasound appearance does not change. The lungs are full of fluid. So do not think that you're going to give surfactant, you're going to repeat a lung ultrasound, and it's going to look better, and that's a sign of improvement. What you're really looking for is clinical improvement in the baby. That's clinical symptoms, FiO2, gas exchange. And really, there then is the question of whether you really would be giving a second dose. And again, the evidence from BRAT study for the use of the lung ultrasound score after you've given surfactant in correlation with a second dose, there weren't enough cases to give us good enough sensitivity and specificity. So I'd just be a little bit cautious at this particular point of arguing that you repeat a lung ultrasound either to see improvement or that you repeat a lung ultrasound maybe a few hours down the line. There's at least one study which has shown that you can actually follow lung ultrasound in extremely preterm babies at 2, 4, 6 hours, and you can actually see the appearance of double lung points, well aerated lung. I still think that I don't have enough high quality evidence to really talk about that second dose. But clinically, I think if you had a very high score in an unsteroided boy, I'd just be a little bit cautious about using LISA and Ensure, because the risk is you may well need a second dose. I'm keen to hear other opinions. So Mayank has an opinion. Mayank, do you want to come in?
Yeah, for definitely before deciding if I had to do a LISA or Ensure, because as per evidence, we are now quite sure that LISA helped reduce mechanical ventilation or BPD or pneumothorax. So going by the evidence, I would definitely, and by the clinical situation as well. So if the baby is on 30% FiO2, I would definitely do a LISA, even on 40%. So the threshold would definitely vary according to the gestational age of a baby who is 26 weeks and FiO2 of probably 50%. I would be more comfortable intubating that baby and giving surfactant, while 30 week with an FiO2 of 60%, I would still prefer LISA. So the clinical judgment is definitely not just risk factors or a single factor. There are multiple things that you have to look for before deciding.
Fair point. I think that's completely correct. And like I said, clinically correlate, look at the baby, make a judgment, risk assess, and individualize your treatment to that particular baby is what Mayank is saying. I think I would still say that some of my colleagues would probably say that high quality evidence that LISA or Ensure or either is any better than the other at this particular point is still out for a little bit of debate. I think in particular, my French colleagues would really argue they don't do LISA at all. And I know that in the UK we do LISA, but my second question is, when do you want to do the lung ultrasound? So the first question that we've kind of addressed with this case is, please individualize. Please make sure that you're looking at the individual risk profile of the baby, right from perinatal optimization to the clinical course and the clinical symptomatology that the baby takes. The third aspect to it is obviously, be careful about making judgments about the second dose based on lung ultrasound alone and scores alone. The lung ultrasound profile does not change immediately after giving surfactant, but clinical follow-up and clinical symptomatology correction is really what you really need to be looking out for. But my second question that I'd like to kind of address in this workshop is, well, when do you do the lung ultrasound? Should we do it at 10 minutes? Should we do it at 30 minutes? Should we do it at 1 hour? Should we do it at 2 hours? Should we do it at 4 hours? So I'm just curious, what is the evidence?
I'm not sure about the evidence, Alok. You are the expert, but
not at all. I would argue I'm not the expert. The experts are Nadia and Al-Medina, and we can ask them. Nadia's back next week, but I'm just curious to kind of pick everybody's brains. So Zaridin, what do you think? Go for it. Yeah.
You are very humble. I think as long as we do the ultrasound and exactly document the timing and the correlating clinical picture, I think that is will be adequate for me, because every baby is individually having its clinical situation. But at the same time, I think if I work in a unit that is incorporating lung ultrasound, I would then sit down and think with my colleagues on a guidelines, exactly the same way that we have a protocol or a guideline for a head ultrasound scan has to be done on, say, day 1 or day 3 and then day 8 and so forth. So I think for the sake of agreement, there should be some guidance for every individual unit on the timing for ultrasound based on gestation and based on degree of maturity and based on the clinical condition, whether it's, say, for example, term with meconium aspiration or PPHN and so forth, or TTN. So I'm not sure which category of patients that you are asking for. Are you talking just for the RDS?
Yeah, just for RDS. So I would talk about babies 22 to 32 weeks at this particular point, and kind of making a judgment for those babies who, say, for example, we're assessing from an RDS perspective. So we're sure of the diagnosis. You know,
I think I would really like to time it along with, if possible, with the scheme for ultrasound scans for head, if it's extreme premature, because this baby is likely to have a head ultrasound within the first at least 12 hours or so, maybe earlier, within the first for a few hours. So just for because minimal handling would be an issue, I think, to convince everyone about repeated lung ultrasound scans.
I think that's beautiful. That's a great answer. So we've got Zaruddin bringing the fact that, look, we're going to do our golden hour. There's going to be a huge amount of handling lines. We're then going to, obviously, as part of the golden hour, there's an element of, well, some units use the ultrasound for lines and a head scan, and there's an opportunity to do a lung ultrasound. So that's one point. We've got a few people. So Anna, would you like to come in? I see that you've commented on the 2 hours. Please, I'd love to have your opinion, please.
No, I don't have these babies in my unit, only, yes, a few babies, but after 28 weeks, not so little. But from what I read, it's in the first hours, because it's when the surfactant would be more benefit for the baby.
Okay, that's beautiful. Yep, Mayank.
We have I scores.
Sorry. Yeah, carry on.
Yeah, it was just the conclusion. If we have I scores in the first scan,
yep,
maybe it's better to do the surfactant sooner, because it's the prognosis is better.
Okay, so excellent. So we'll summarize that as well. That's a really good point. Anybody else? Mayank, you have a view?
Yeah, frankly, we actually didn't use to do lung ultrasound, but as now we have started doing so, I feel that it can be clubbed with, and we actually club it with the cranial ultrasound, as well as when we check for lines. So as Zaruddin was saying, definitely we would like to club this with other ultrasound examinations.
Sure. I'm keen to ask Dr. Yong, Jean, what do you guys, I know you're not doing lung ultrasound in Oxford at the moment, but just as part of your golden hour, when do you kind of do your scans, and what is your golden hour like in Oxford?
Yeah, so now that we're instead of resuscitation at birth, we try and help babies transition after birth. So we have initiatives like high flow from birth, birthday cuddles, delayed cord clamping, and all of that sort of optimization around the time of birth. So naturally, that golden hour has become a bit longer. So generally within the first hour and a half or so, we try and get all of the lines in. And then we use POCUS for line insertion. So we use those to confirm our lines before an X-ray. But at the moment, I think just myself and another colleague do lung ultrasounds. So it's very variable on whether or not somebody's actually on at the time. So at the moment, we mostly go by FiO2 requirement, what the blood gases are like in terms of respiratory acidosis, and how the baby is clinically, so their work of breathing and the consistency of that. But generally, if the FiO2 is above 30% oxygen, we give surfactant. So we tend to give it sooner rather than later. And if the baby's stable, we go for LISA. But I think if baby's going to need 2 doses of surfactant, it seems like 2 quite invasive procedures. And of course, you would need some pre-medication with that. So it would seem more beneficial, if baby was looking like they were going to need 2 doses of surfactant, to intubate and then give that more easily. But generally, as a routine, we tend to use LISA, and we use video laryngoscopy with that mostly.
Okay, so I think we're getting some flavors over here. Anybody else have an opinion?
Just look, one comment. For the second ultrasound after the first dose of surfactant, sorry. So I think before deciding the second dose, in any way we will give the second dose between after 4 to 6 hours for the benefit of the baby. So if we can do it 6 hours after the first dose, I think, I don't have any evidence, I didn't read about it. At 6-8 hours, could be better to do this ultrasound to decide for the second dose.
So my practice, Dr. Sharif, is I don't use ultrasound to decide on my second dose. I think if I'm kind of in a situation where I have a baby who's tubed, and if he's in any FiO2, I would and I would give them the second dose. I'm not saying I'm doing the correct thing, but again, I would just throw a little bit of caution to the use of lung ultrasound, looking for improvement based on scores and the ultrasound profile. And I don't think there's strong enough evidence at this particular point to kind of say that we can confidently use it in isolation to guide us with regards to whether we should redose or not. I think the experts, and I would, when we're going to have a panel discussion with Nadia and Almudena, it's a question that I would put to them. But the one thing that I would definitely allude to, so I think Sharif wants to come in again. Go for it, Sharif. Yeah?
No, I think that was Muhammad. That was Dr. Muhammad, not me.
Okay. Oh, my apologies.
No problem. But I just have a comment when you finish.
Yeah. Sure. My apologies. So what I was going to say was that in terms of reviewing the evidence, most of the work for use of surfactant treatment based on lung ultrasound has been done by studies that have been done in the first few hours, really the first 2 hours of life. The second thing is there's at least one randomized control trial that's been done in Spain, which actually shows that using lung ultrasound was a better predictor than FiO2 at being able to make a judgment for giving surfactant. And it actually resulted in, improvements in the baby compared to using FiO2 alone in terms of their response to treatment, that you were able to treat those babies with surfactant earlier. Now, there's a school of thought which basically says that by the time babies have hit an FiO2 of 30%, you've kind of, in some cases, because that might take 6 to 8 hours, you're giving surfactant quite late. These are babies who then kind of don't have such a good outcome. So really, for the people who are using lung ultrasound scores, they tend to assess their babies within the first 2 hours. I'd also say that most babies, who are being treated using lung ultrasound at this particular point, tend to either have intubation, LISA, or INSURE as kind of modalities, but using a lung ultrasound score of, say, 12 or 14 to decide that I want to intubate this baby versus, say, for example, saying I want to LISA this baby. There are no studies which have actually looked at the severity of the lung score to decide on what approach you would take to management. That's a very key take-home message that I want to give all of you. I would say it's your clinical judgment at that point, looking at the individual circumstances. And if I had a lung ultrasound score of, say, 6 in a baby who is a boy, who's 28 weeks, who has significant work of breathing, who has an FiO2 that's hitting 30%, actually that lung ultrasound score is not high, but this is an unsteroided boy. So actually I might use a slightly lower cutoff for the lung ultrasound score to treat that baby. And I think that's where I would come back to you to say that while traditionally the books and the articles that you'll read will kind of use lung ultrasound scores of 8, and I know some authors actually use cutoffs of 6 to kind of increase and help with earlier treatment. I think what I would do is I would try to individualize on every case on a case-by-case basis, trying to risk assess and trying to do my lung ultrasound usually within the golden hour. And it comes back to the point made by Dr. Zaruddin that actually if you can club it with all the handling that you're doing in one go, so you do your golden hour where appropriate, you cite your lines, you get them in, and really if they're warm enough at that particular point, you do a sweep to confirm your lines, your head, to make sure there's no IVH, and basically then do your BRAT score all in one go. And you really want to keep that to less than 5 minutes of total exposure, especially the more preterm you are. A 22, 23 weeker, 5 minutes, you've lost all your humidity. So that's the kind of approach that I follow. That's one approach. There are some people who follow an approach of wanting to do the lung ultrasound as early as 60 minutes. And again, what I'd say to you is that's perfectly acceptable, but do not compromise your management. I think at 60 minutes, there might be other priorities. If you have a baby that's cold, that is freezing, that is unrecordable temperature because you've just come in and you've finished lines, maybe doing a lung ultrasound at that stage is not such a good idea. As a head scan, you probably want to get the temperature up. But I'd just argue to you the hypothermia and the damage that that's doing and the surfactant inactivation that that's causing is probably just as harmful. The lung ultrasound will probably only reveal what you need to do because of the damage done by hypothermia. So please individualize. Again, develop your own local guidelines based on the evidence. But again, we'll ask the speakers what they think. Dr. Sharif, do come in, please.
Yes, thank you. So you covered most of what I need to say, Alok, about that. So each baby need really to be individualized. Like in my current trust, I do probably the same as Dr. Young said at St. Peter's Hospital. We are doing based on resuscitation, based on high flow, moving towards non-invasive kind of ventilation at the start and keeping the baby some time with mom. So it's very important to look for the first hour, which is very, very important, as you said, for the baby in terms of temperature, birthday cuddles, and all this kind of stuff. So I agree totally with you. We are like lung ultrasound is very, very helpful, but it shouldn't be the only way to judge whether this baby needs surfactant or no. So we go clinically plus the lung ultrasound stuff.
That's really helpful. So go for it. Somebody's
Look,
coming.
My comment was after the follow-up ultrasound after the second dose of surfactant. So just to make it clear, so when we should do it?
So I don't. I think if the baby's clinically improved at this particular point, the baby's come down to air. Let's say the baby was one of those babies who fit into a kind of a poorer prognostic category, no steroids, boy, extremely small, very high risk of RDS. My experience is those babies inevitably stay tubed, and I give them the second dose anyway. So my argument then is a second lung ultrasound is not really going to alter my management. What I would say is where lung ultrasound does help me, and this is just a recent case that I've managed, is I've got a baby where I've given the first dose of surfactant, and actually this baby is still in lots of oxygen. It made no difference. The baby's in 60%. Again, what I want to do is I want to go in and I want to do a lung ultrasound there because has the baby got a pneumothorax? Especially before giving my next dose. The surfactant might have gone down the right main bronchus. And it's really interesting. I did the lung ultrasound in that baby. And what I detected, having given that first dose after the baby was intubated, was that the right lung basically was well aerated with a predominantly AB profile, but the left lung was completely white with a kind of a white lung profile everywhere, including the posterior areas. It's a surfactant, even though the tube was in the right place, it got down the right main bronchus. So I think it's kind of a targeted approach to trying to determine what the indication is, but just a routine kind of lung ultrasound to look for improvement. No, I don't do it in my practice. I know that there's one piece of work, I'll share the articles with you, which basically looks at improvement after surfactant. And basically what they say is that you really start seeing decent lung aeration about 4 hours after, and really improvements, good improvements at 6 hours, but I think, again, surfactant recycles really well. And I think you have to be really careful that a lot of these babies will often have secondary surfactant inactivation for a variety of reasons. Some of these babies will become hypothermic when you handle them. Some of them will have significant chorioamnionitis, which means they honeymoon really nicely at the start, but have significant sepsis or GBS sepsis, which causes surfactant inactivation. So my own practice, I'm not saying it's evidence-based, is I think if the baby's tubed and in any oxygen, I usually will give them that second dose at 12 hours if really they're not crashing and burning. But I think if they're kind of in a situation where they haven't responded to that first dose, I really want to know by lung ultrasound or where you work by a chest x-ray, well, what is wrong? And part of that workup I've picked up a baby where actually we repeated the lung ultrasound and you had a right upper lobe kind of, a complete white consolidation with no vascularity and no pleural line. And we checked the tube and the tube was basically far in. And it was a simple thing like that. We pulled the tube back and actually you're able to aerate. I mean, we did get an X-ray and we picked up that the baby had a right upper lobe collapse. So I think it's really good in the circumstances where you might not have had a response or your baby is deteriorating. But I think empirical use of the lung ultrasound for the second dose, it's not part of my practice. I think that's a question we should put to Nadia when she gives us the next talk, and to Al-Medina when she speaks to us next week. Is that okay? That's really helpful. So we're going to go to one more case before we call it a day, guys. It's a nice case. So what we're going to do is I am going to get the lovely Margarita. Can you hear us?
Yes.
Okay, so Margarita, this is a 29-week baby who's 8 hours of age. And this baby basically is, again, a baby girl. The baby has delivered precipitously, bulging membranes when the mother came in. There was no time to get any steroids on board. Clearly, from our perspective, the baby came out and was actually decent sized, about 1.2 kilograms of weight. Did well, CPAP'd, grunting for a bit, but actually on a CPAP pressure of about 6 to 7, has kind of now settled down into about 28% oxygen, has got decent CO2 clearance. The baby's about 8 hours of age. And now at 8 hours of age, the FiO2's crept up. It's about 32%. CO2 clearance is still decent. So we're kind of doing a late ultrasound. We did a chest X-ray initially, which showed moderate RDS. I'm not showing you the chest X-ray on purpose, but these are the images. So this is R1 and R2 for you.
Okay, the pleural is sliding nicely. It is a bit coarse. It has a consolidated B profile, consolidated in and subpleural consolidations. They are more evident in R2.
Beautiful. Yep. So, I mean, we think this is RDS at this particular point, and I would always say you need to obviously see your entire scan before you make that diagnosis, but I'm going to say that yes, this is RDS.
Probably if it continues like this, it will need surfactant, of course.
Yeah. So what scores are you going to give this baby?
What
scores based on the BATS?
Okay. 2 and 2.
R1, R2. Yeah. 2 and 2. Fair. I think that's okay. That's perfectly reasonable. Okay. So now these are the next set of images, and just to say, R2 is basically a still image of the previous image, so don't worry, but this is R3.
Okay, I think it's the same. There is the sliding pleura. There are, it's B profile.
Yep.
With some subpleural consolidations more on the left side.
Okay, excellent. So, yep, absolutely. So would you like to critique this? Any critique that you'd like to give?
To the image?
Yeah.
Well, the image is a bit blurry.
Yep.
And these images just go to the down. Okay.
You're absolutely right. That's the point I was going to make. That actually, as we go down, we obviously get these dark areas from the ribs, which is acoustic shadow.
Yes.
But clearly we're losing out on this particular region. So maybe just dropping the frequency a bit will give us and will tell us that there are deeper subpleural consolidations. And I mean, classically what you can see at this particular point, this is the previous image. And if I just play them again. So you can see much better penetration on the previous images as compared to this image. So a little bit less in terms of dropout there, but on this image, there's more dropout. So again, what I'd say to you is play with your frequency a little bit to try and optimize your images, because the risk is you might miss deeper consolidations. I mean, what you do have is completely B profile with subpleural consolidations. You're happy with a score of 2?
Yes.
That's 6 for the right side.
Yes.
Okay. So, I mean, I decided to do the R4. So again, And I'm doing the R4 in posterior axillary line.
R4 is a B profile too, a score of 2.
Yep.
And R4, it's a bit better because we see A lines.
Yep.
And well, it might be a 1, 2.
Yeah. So again, it's just R4 is actually R5, but it's to say that, the posterior lung fields, they actually look better. Any reasons why you might think that's the case? Anything that I'm doing that is making that the case? Would you like to comment? What have I done to try and optimize this baby?
Oh, let me see. You wrong position. No, you change your settings, your frequency. And
no, I haven't actually. So this baby's prone.
Oh, but if okay, it's prone.
Yeah, which is why the R5 looks a little bit better. So just because this
baby
you
was starting in the front before.
So basically, yes. So I started at the back first, but I'm showing you the images in that order. So for nomenclature purposes, I'm showing you the images in the order that you're interpreting them. But actually, when I did the scan, I started with the back first.
We need to wait for 1 hour before we, if we don't want to be, if we want to go to do a right evaluation, we have to wait 60 minutes to evaluate the other part.
So the purists would say that, but actually what Nadia's group would do is they would do R1 and R2 at the back, and basically do the lateral region and not do the front for the BLAT scoring.
To try to find the worst of the lung.
No. So what I'd say is that normally the study that was done by Rosalind Bratt was done with the baby supine.
Okay.
So they did R1, R2, and then they did one lateral zone, which is basically the 6 partitions and assign scores to 6 spaces. But what Nadia recommends is that if you have your baby prone, I mean, some people will have the practice of turning the baby supine and waiting. But actually what she says is you can actually do the back similar. So you do R4, so R5, R6, and then you do the lateral zone. And you do L5, L6, and then do you get what I'm saying?
Yes.
So actually the correlation between that, and they've done work on it, they've done further studies on it, it's exactly the same.
Okay.
So you don't have to turn the baby if you don't want to.
Okay.
I know that Almedina, when I asked her this question, said that they would turn the baby and actually they would give it 60 minutes.
Because one thing that we're talking, it's these babies in the first hours, they don't like to be moved and they don't like to be touched. So everything that we do will make him worse. So
so it's to say that you can actually just use the back like you'd use the front and not move the baby. And that would be just as acceptable for doing the BRAT score.
Okay.
And that's what they do in Paris. So, I mean, you're right. I mean, when we look at the score at this particular point and you look at it, and I'm just going to show you a few images of L. So we pretty much have a score of 6 on the right. What about on the left?
Okay, on the left, can we say that is a small consolidation near the heart?
Beautiful, well done, absolutely amazing. Can everybody see that?
It's a tree.
Yes.
So can you see this? Can everybody see this?
Yeah.
So again, staying with the order, there is basically pleural sliding present, very irregular pleura, subpleural consolidations, so a mild snowflake sign, an AIS kind of pattern. But when you look at this area here, now always remember, this baby was prone, and with prone babies, like I said, collapse consolidation in the deeper parts of the lung needs to be considered. Now that is basically either collapse or consolidation at this particular point. It's very hepatic. It's got a margin. It's just subpleural, but it's a big subpleural consolidation that you can see over there. And it's just an example again of how you can pick up bigger subpleural consolidations in babies like this. L3, again, what do you think about that, Dr. Figueroa?
There is pleural sliding, the subpleural consolidations, the B profile. But I think in this, I can't, but just that, the two profile.
So what else can that shadow be in L1? Anything else? Anybody?
It can be the thymus.
No, the thymus would not be that low with the consolidation above. That would be unusual. It would be above. I'm too low actually. You'd kind of get the thymus above the lung there, but that's actually hard coming in at this particular point. So I mean,
a mirror image.
Yeah, I mean, what I'd say to you is that I don't think it can be a mirror image because you have heart. But if that was spleen or liver, and this was on the right side, that could be a mirror image. My feeling is that is consolidation because the heart would not give you a mirror image that's tissue-like.
And in the left there is the spleen, but spleen can be.
Yeah, it'd be too low. Yeah, you can't see it here. Hence, but I'm just giving you a kind of, if this was lower down, you need to consider the possibility that this could have been a mirror image. It's not.
Why do you think this is consolidation rather than anything else?
So do you agree with me that it's tissue-like?
Yes.
Okay. You can see pleura in contact with it. So if there's pleura in contact with it, which is irregular, there must be air hitting the pleural margin.
Yeah.
So if there's air hitting the pleural margin, that tends to go against atelectasis.
Yeah.
Again, for all those reasons, I would say that that is a consolidation. What I would also do is put Doppler on it and see what the vessels are like. But if say, for example, from my perspective, it's hugely vascular, you could argue that, yeah, is that a mnemonic consolidation? Again, clinically, my CRP in this baby's case at this age was just 2. So I don't have enough going for a mnemonic consolidation. So I'd probably label that as a consolidation at this stage.
Thank you.
So, I mean, just in the interest of time, because I know I don't want to kill all of you. We need to get you off on time. You know, this baby is probably kind of scores really good. Now, how do you want to manage this baby?
Yeah.
So I set a PEEP of 6 with 8 hours of age. He's 29 weeks, unsteroided girl.
Well, she would appreciate the dose of surfactant.
Okay.
It could be Lisa, although big babies, they struggle more than small babies for Lisa.
Okay, so we have a few thoughts there. So some, does anybody want to do anything? Does anybody not want to give surfactant? Could you just type into the message box if you don't want to give surfactant to this baby? So you're in about 30%, you're a PEEP of 6, your CO2 clearance is okay, but you have significant recession, you have these lung ultrasound appearances. So Anna's kind of mentioned we can increase PEEP. That's a fair point. You could go up to 7, maybe even 8. But anybody else want to try non-invasive? NIPPV, okay. So Margarita's clearly said we can give this baby a trial of NIPPV. That's a fair point. Okay. So a few kind of options there. Based on the lung ultrasound score, I think clinically we'd agree that this baby should probably have surfactant. My only comment is that the longer you wait, the risk that this baby is going to miss the benefits of giving surfactant. Your 8 hours of age go up. And then the question is how efficacious the surfactant will be, because you'll have more established hyaline membrane disease. And my only other comment about using higher pressures in the COIN study was that there was just a higher risk of having a pneumothorax. And that risk was about 10%, for the babies between 25 and 34 weeks. So, those are the kind of risks and benefits. My clinical feeling is I'd probably bail out, no steroids. I'd probably, in terms of treatment, I'm going to leave it open. I'm quite happy. There's some people who might opt for Lisa. I think that's reasonable. Somebody might want to kind of give Insure. put a tube down. I'm not going to go into the intricacies of doing that. But I think really from my perspective, at this particular point, I think based on lung ultrasound, you'd probably opt towards giving this baby surfactant in one form or the other. Just a very quick kind of overview of how easy it is for you to miss consolidation in circumstances like this. You have to really watch very carefully. And again, that area over there, it just shows what a deep consolidation can look like for a baby in prone position. This again, I'm not going to go to the case, but this is just an example of what high gain settings can really exaggerate what you're looking at in terms of a B profile. This is a baby who's basically in about 25% on a PEEP of 6. And really, this baby is with good gas exchange, with not much work of breathing. And I'm just giving you the right lateral lower and the R3 region, which is obviously this baby's supine, but I have very high gain settings. And the problem with having very high gain settings, also, again, what I'd say is that you can exaggerate how the lung actually appears. So just be careful about using very, very high gain settings in situations like this. Any questions about today? Anybody have any questions?
I have a quick question.
Yeah.
The other day, Nadia has put some emphasis on the presence versus absence of diaphragm as a landmark. So how does that kind of play a role in general in lung ultrasound as an important landmark to obtain?
I think for work of breathing, are we talking about work of breathing and quantifying kind of intubation for the baby?
No, sorry, not in the context of just because of the last few images. We had a lower left scans, which are probably, I was just wondering whether we can see the diaphragm or diaphragm is still lower and it's not been captured.
My gut feeling is because I'm using the hockey stick, it's not been captured. Can you see? I've only literally got 1.5 intercostal space. And that is, I mean, that's why I like using the linear probe. I'm going to say to you, and this is why I like using the linear probe. Can you see the difference? So this is a linear probe, same baby.
Yeah.
And you just capture much more in terms of kind of the architecture. You're catching much more geography. I mean, everybody would probably agree this baby's got a complete whiteout lung, but again, it's just an example of quite a severe fractal sign in a baby who's got severe RDS. And again, it's to say that who's to say you can't have infection in babies who've got respiratory distress syndrome? You have risk factors, ruptures of membrane. So you can have babies with chorioamnionitis who have fractal sign as well, and and have coexistent RDS. So this is a really good example of that subpleural consolidation seen. But again, the problem that we faced with the previous scans is because I'm using a hockey stick with a very small footprint, I'm not seeing the diaphragm, though, because I can take multiple lower images to be able to get there. But actually, when you use the linear probe, you just get much more better anatomy definition. So anybody want to comment on this before we finish?
Hi, I have a doubt about the area of the focus that you are using in these images. So do you prefer a wide area to focus or a point, only a focus point?
No, if I'm looking at the pleura, and as you can see over here, I will keep the focus at the level of the pleura. If I want to look at deeper structures, I might bring the focus down to those deeper structures. But more importantly, what I would do is I would probably drop my frequency along with that. But for most of the images, what you want to do is keep your focus at the pleural line and alter your frequency. So, I mean, the frequency here is decent. I'm getting all the lung with the frequency I'm currently using over here. But focus, if you want to see pleural sliding, if you want to see subpleural consolidations, if you want to focus on areas underneath or just beneath the pleura, you really need to keep the focus at the level of the pleura. Now, this is a Philips machine, which we have to adjust focus in. If you're using a GE, you don't have to adjust focus. Again, this is a Philips machine with a linear probe, where, theoretically, you can. So can anybody see the pleural effusion, guys? There's a pleural effusion there. This is RDS, and you can see pleural effusion, small pleural effusions with RDS. Again, there's a little bit of lung atelectasis there, a complete alveolar interstitial syndrome in multiple lung areas. I mean, it's a white lung for this, and you have very severe fractal sign. And I would Doppler this area to look for vascularity. One last question, guys, before we finish.
Yeah, hi, Doctor.
Yeah.
I have two small queries I have all put up in the chat box as well. So, as you were showing the images from the hockey stick probe, so if the probe has a small footprint and there's discrepancy between the two scans of the same area, like if I'm scanning in R1 and I have two scans for the same, and there's discrepancy, so which one should I use for the
Higher
scoring?
score. Higher score.
More severe one. Okay, right.
Yeah, you always
And
use the
and the second query was, there are sometimes scans which are actually neither one or two, it's in between. And so how do we go about scoring those scans images?
You get, so I get another colleague to review, and two people agree on what they think the scores are.
Okay.
And that basically takes the subjectivity out of it. The one problem that I would say with Brat's score, that it doesn't quantify deeper consolidations. Again, which can be seen in the posterior areas. And like I said, there's some babies who will have well-recruited anterior areas who are supine or prone, and you're basically missing consolidations in the deeper areas, which might give you a higher score. And that is the one argument that people use for the 12 region scoring methods and scoring posterior regions. So far, meta-analysis and current evidence doesn't show that they're any better. So my view would be that use Brat's score. It's easy, it's reproducible. And if you're confused, it's borderline between these two scores, get a third person to come, like if you disagree, the third person then, basically is the person who then gets the winning vote. Experience says, it's not so difficult. So with experience, the score of kind of 0, 1, you should be able to kind of differentiate, because 0 is technically normal lung. Do you get what I'm saying? So, so the way I look at it is, once you start saying more than 3 to 5 B lines in each intercostal space, for me, that hits a 1.
One of the scans that you showed was actually, I was thinking in L3 was 3, but you had scored 2. So I was a little confused. I thought it was definitely more than 2, but less than 3. So
I mean, and again, there are authors who basically say that we need to have subclassifications of 3, because 3 as described in Brat's score looks very severe. I think I would say, don't overthink it too much. Don't overthink it too much. Clinically correlate, look at your baby, look at the history. Start from perinatal optimization. And my experience is, use the scores in that context and you'll always be correct.
Right. Thank you.
Yep. And Anna's correctly pointed out, Nadia said once we can use 0.5. I think lots of really nice questions that we have for Nadia's next talk. I've written them all down. So what we'll do is we'll give her a little bit of a grilling. So is that okay? I'm really grateful, everybody, again, for your patience. I'm sorry about the length of the sessions, but I hope you're learning. The next session for me is very important. Pneumonia, collapse, consolidation. We're going to talk a lot there. Again, practice, lots of presentations. And then what we have is a period of giving you a rest for the first week of March, after the 1st, to let you recap, keep doing scans. We will have a lot of peer review, but the 7th, the 6th talks, we will not be doing peer review, just for you to focus on the talks and ask questions about your doubts. You have 2 expert speakers coming in. You have the ability to ask them questions from any part of the curriculum. They are fantastic guys. So I don't want you to stress too much about having to share images. We will start again after the 7th, but on the 1st, we have another session coming up and we will have 45 minutes of peer review. God bless you all. Thank you so much.